Okay, so this is chapter 26, toxicology. And this is the study of adverse effects of chemicals and drugs that are not typically found in the body. So xenobiotics, as we said before, are the chemicals and the drugs that are not normally found in the body or produced by the body. Mechanistics, the mechanistic toxicology talks about or elucidates the cellular, molecular, and biochemical effects of the xenobiotics. So basically, there are three major disciplines in toxicology. That's what I forgot to say. So the first one is the mechanistic type of toxicology. So it will describe the cellular, the molecular, and the biochemical effects of xenobiotics, of drugs. And then there's descriptive toxicology, which uses the results from animal experiments to predict what level of exposure will cause harm in humans. So risk assessment, that's descriptive toxicology. And regulatory toxicology is the using combined data from the mechanistic toxicology and descriptive studies to establish standards that define the level of exposure that will not pose a risk to the public health or safety. So basically, these are the type of regulations that are overseen by governmental agencies like the FDA. So we'll talk about some of these governmental entities that oversee these toxicology results in labs. And it is true, toxicologists work closely with regulatory agencies like the FDA, the EPA. So the FDA deals with human safety issues associated with therapeutic drugs, cosmetics, and food additives. The EPA is the U.S. Environmental Protection Agency, and it oversees pesticides, fungicides, rodenticides, and industry-related chemicals that may threaten safe drinking water and clean air. OSHA, as you know, is responsible for ensuring safe and a healthy work environment. The CPSC is Consumer Product Safety Commission, and they regulate household chemicals. The DOT is the Department of Transportation, and they oversee transportation of hazardous chemicals. So xenobiotics, poisons, and toxins are terms that are often used interchangeably, but they should be differentiated, basically. Xenobiotics, again, are the exogenous agents that can have adverse effects on a living organism, right? Poison is actually a term that is used to describe substances from an animal, a plant, or mineral or gas, like venoms from poisonous snakes or spiders. Toxins are endogenous substances biologically synthesized either in living cells or in microorganisms. So botulinum toxin is produced by Clostridium botulinum, and that's an example of a toxin. So here's some routes of exposure. Well, toxins, poisons, right? They can be inhaled, they can be ingested, or we can be exposed through transdermal absorption, which is the most common way. The clinical setting is the most common way. In the clinical setting, ingestion of a poison or a toxin is the most common route of exposure. A toxin needs to be absorbed into the circulation. Most are taken up by diffusion, by passive diffusion. Hydrophobic substances are able to cross all cell membranes and can be absorbed anywhere along the GI tract. Ionized substances cannot cross cell membranes, and absorption in the GI tract depends on the rate of dissolution, GI motility, resistance to degradation in the GI tract, and it depends on the interaction with other substances. Some of these terms you're already very familiar with, but we use them in toxicology as well. So an assay sensitivity is the lowest concentration of an analyte that can be measured by a particular method, right? That's the sensitivity. We can measure drugs either qualitatively or quantitatively, right? So positive, negative, or give an actual number. So a cutoff value is also known as a threshold value. It's the value or the concentration of a drug of abuse, which is used to determine negativity or positivity in toxicology. This is used to report out a drug screen. All right. So all substances have the potential to cause harm. So that's basically the central theme, the central dogma of toxicology. All substances have the potential to cause harm. The dose makes the poison. The dose makes the poison. That's like the idea in toxicology. It is very important to establish an index of the relative toxicities of the substances. Most systems correlate the dose of a xenobiotic that will result in harmful effects. The dose-response relationship, dose-response, implies that there will be an increase in the toxic response as the dose gets increased. Not all individuals display a toxic response in the same doses. So that's something that we always keep in mind. TD50 is the predicted dose that would produce a toxic response in 50% of the population, TD50, the predicted dose that would produce a toxic response in 50% of the population. ED50 is the dose that would be predicted to be effective or have a therapeutic benefit in 50% of the population. So a therapeutic index is basically a calculation of both of these, TD50 over ED50. So the drugs with a large therapeutic index demonstrate fewer toxic adverse effects when the dose of the drug is in the therapeutic range. All right, let me repeat that. The drugs that have a large therapeutic index demonstrate fewer toxic adverse effects when the dose of the drug is in the therapeutic range. All right, so there's two types of toxicities that we could encounter. There's the acute versus the chronic toxicity. So this depends on the duration and frequency of exposure to the observed toxic effects. Acute toxicity is a single short-term exposure to a substance in which the dose is sufficient to cause immediate toxic effect, right? A single dose or short-term exposure. And chronic is more associated with the repeated or frequent exposure for extended periods of time. So it could be months to years at the doses that are insufficient to cause an immediate acute response. So that makes sense. Acute versus chronic toxicity. So the analysis of certain toxins and poisons are performed to screen for agents that might be present. So we often refer to that as drug screens. We also do heavy metal panels and targeted testing. So that's done when an environmental risk of exposure is known, usually done in chemical plants or for industrial workers. We do targeted testing to also comply with occupational regulations like OSHA to confirm clinical suspicion of poisoning and to diagnose or as a diagnosis of toxin exposure, which depends heavily on lab testing. We can use urine or blood specimens. The selection of specimen depends on which toxin is suspected. And the specimen type and timing of the collection should be relative to the time of exposure as well. For example, exposure to methyl mercury is only seen in fecal material. So it could be missed if we're looking for it if we use urine to detect it, right? Also, exposure to arsenic could be missed if the testing is done a few days after exposure, because arsenic has a very short half-life. So in terms of analysis, we avoid any type of external contamination of the sample. Sometimes patients' clothing can contaminate samples, skin, the hair, the collection environment. You want to avoid specimen handling issues like the types of container that you're using, the lids, the preservatives in the containers. The analysis is usually a two-step approach. So we usually do a screen test first, which is a presumptive, rapid, simple, a qualitative test that provides a positive or negative result. And then you perform a confirmatory test. It's a more specific test. It's usually quantitative, so it gives out a number that provides the actual concentration of the substance. So almost always the assays are specific for a single type of drug that we're looking. So for example, THC, I'm sorry, I have a typo in there. So assays can also detect drugs within a general class. So some examples are the TLC assays, thin layer chromatography. These are simple and inexpensive methods. We can use gas chromatography. These are GC methods that are widely used for the qualitative and quantitative analysis of many volatile substances. And gas chromatography coupled with mass spec are typically the reference methods for many of the drugs that we're looking for. Okay, so we're going to talk about some specific drugs here. Overdose situations are commonly a result of accidental or intentional excessive intake of pharmaceutical drugs. All drugs are capable of toxic effects when improperly administered. Commonly tested drugs in the clinical lab are acetaminophen and salicylates. Salicylates are also known as aspirin, right? So these are commonly used analgesic drugs, also anti-inflammatory drugs. They interfere with the platelet aggregation, and also they interfere with GI function. It's associated with metabolic acidosis. The biggest problem is maintaining electrolyte balances. Also, aspirin or excessive intake is associated with excess ketone body formation. The treatment for the excessive intake involves neutralizing and eliminating the excess acid and maintaining the electrolyte balance. The Trinder reaction is a commonly used assay. It's a chromogenic acid in a lab in which the salicylate will react with ferric nitrate to form a color complex that is measured with a spectrum. It's measured spectrophotometrically. Acetaminophen, also known as Tylenol, is commonly associated with severe hepatotoxicity, so liver damage. It has a low free action that binds to various proteins, and the liver cannot process large quantities of this. The liver, to know, is does not. The liver does most of the uptake of the protein-bound acetaminophen. The kidneys have little to no involvement, so that's why we don't usually test the urine in a case like this. The damage of acetaminophen can occur in 3 to 5 days after excessive intake of this, and it clears quickly from the serum. So, okay, sorry. So we also measure different types of drugs of abuse, right? And that's commonly done in a clinical lab setting. Screening single urine specimens for many substances by qualitative test assays can be done. A positive drug screen cannot determine a single use or chronic abuse, and it also does not determine the time frame or the dose of the drug that was taken. The most critical are the substances that have the addictive potential, And most of the testing is performed on ER specimens, the emergency room specimens. Patients come in through the ER disoriented, unresponsive, and with with a suspected case of overdose. So here are some examples of the drugs of abuse that you may or may not measure in the lab, in your lab in particular. So benzodiazepines are the type of medication known as tranquilizers. Some of the familiar names for these are Xanax and Valium, and they are some of the most commonly prescribed medications in the United States. When people without prescriptions obtain and take these drugs for their sedating effects, oftentimes it turns into, a drug of abuse. So with benzodiazepines, we do not report out presumptive. Why do we report out a presumptive positive? Well, because it's presumptive, right? So it's just a screening part of it. Confirmatory testing needs to be done. So when you do confirmatory testing, it cannot be with the same methodology that was used for the screening tests. We use more specific tests, more specific methods than the screening tests. So the best and the most commonly used methods are gas chromatography or mass spec. So you probably, if you were in chemistry, you probably would be the meth tox cartridge, the immunoassay with the 3 tracks, right? So it's different drugs that could be measured. The track 1 has the THC, the PCP, cocaine, track 2 opiates, track 3 and benzodiazepines, barbiturates. And we use threshold values to report out drug screens. So basically a negative drug screen would indicate the absence of a drug. The presence of a band on a cartridge means that the result is negative. So drug screen specimen of choice is urine. But the urine can also be adulterated, so we have to keep that in mind. So water can contaminate detergents, bleach, vinegar. So direct observation oftentimes limits that. It limits what gets brought into the bathroom. The water needs to be off. Sometimes they put dye in the toilet water, and they take the temperature of the urine immediately to make sure that hasn't been tampered with. Also, the specific gravity. So when the specific gravity is less than 1.003, there's a chance adulteration has happened to the urine. So we only do drug screens for medical purposes. So labor and delivery, based on the doctor's orders, or also the samples from the ER. Drug screens are also commonly done in sleep clinics. We do not do pre-employment drug screens in our lab, but you will get them done when you have to get in, as an employee. The chain of custody is defined as the process where every aspect of collection, transport, and analysis of a specimen can be identified. And that's part of the drug screen. Okay, NIDA. NIDA is the National Institute of Drug Abuse. It's part of the NIH. It's a government agency that set up the drug screen panel with the DOT, the Department of Transportation. So these are the drugs that are commonly screened: THC, cannabinoids, cocaine, opiates, amphetamines, PCP, barbiturates. Benzodiazepines are actually not part of this DOT panel. So NIDA basically has a mission, and that's to advance science on the causes and consequences of the drug use and addiction, and to apply that knowledge to improve individual and public health. So we'll talk about some of these examples and what they do. Amphetamines are central nervous system stimulators. They are medically used to treat obesity, narcolepsy, and also attention deficit disorders. They cause the initial sense of increased mental and physical capacity along with perception of well-being. The effects, though, are followed by restlessness, irritability, and psychosis. Overdose of this drug can cause hypertension, cardiac arrhythmias, convulsion, and possibly death. Some components related to amphetamines are over-the-counter ephedrine, pseudoephedrine, and phenylpropanolamine. So ephedrine was and I think ephedrine has been banned actually. Analysis of a parent drug is used to find the amphetamine abuse. Immunoassays are used as screening methods, so positive results are considered to be presumptive positives, but those must be confirmed. So an example of this is MDMA. MDMA is, okay, I'm going to try to say it. I think I'm going to butcher this name. 3,4-methylene dioxane methamphetamine. Okay, I think I did it. And so this is a synthetic drug that alters mood and perception, and basically the awareness of the surrounding objects and conditions. It's very chemically similar to stimulants and hallucinogens. And it produces a feeling of increased energy, pleasure, emotional warmth, and distorted sensory and time perception, basically. So that the amphetamines derivative is known as ecstasy. That's administered orally in tablets of 50 to 150 milligrams, and the circulating half-life is about 8 to 9 hours. Cannabinoids it's the psychoactive compound found in marijuana. The TCH is the most, I keep saying TCH, it's THC. Sorry, THC is the most potent and abundant. It's derived from the leaves of the cannabis sativa plant. And it is a psychoactive drug. It causes euphoria, relaxation. It's generally smoked and occurs very rapidly. The high peaks at approximately 30 minutes and lasts several hours and impairs intellectual performance, motor skills, etc. So marijuana is the dry leaves, the flowers, the stems. So when the term marijuana, it refers to all of that, the dry leaves, the flowers, the stems, and the seeds from the hemp plant. And it's the cannabis sativa. And the plant contains the mind-altering chemical. In the THC is actually called delta-9 tetrahydrocannabinol. Delta-9 tetrahydrocannabinol. So it's THC. And it also has other related compounds as well. But these extracts are made from the cannabis plant, sorry. So the half-life is about 1 day for the casual user. And a chronic user or heavy consumers would be about 3 to 5 days. It can be detected 3 to 5 days in a single time, time user, and up to 4 weeks in a chronic user. So again, tetrahydrocannabinoid is THC, and with passive inhalation, it can be detected below the cutoff values. We use immunoassays for the screening tests and GCMS for confirmatory tests. Okay, where am I? Cocaine. Okay, so we measure cocaine and its metabolites as well. It's an alkaloid compound administered directly or inhaled as vapor. It's a free base known as crack, and the free base form is known as crack. It's found in the leaves of the coca plant. It's commonly found in South America, and the half-life is about 30 minutes to 1 hour. It's a central nervous system stimulant. It causes excitement and euphoria. And it has some serious adverse effects like tachycardia, seizures, coma, or sudden death. Cocaine is metabolized in the liver. The primary metabolite is benzoylecgonine. For single users, cocaine can be detectable for a few days. For chronic users, it can be detectable for up to 20 days after the last use. The primary screening test for detection of cocaine is the measurement of the metabolite, the primary metabolite, benzoylecgonine, in urine immunoassays. And confirmatory testing is commonly performed using GCMS. Opiates is a general term that is given to those substances that have morphine-like properties. They're capable of analgesia, sedation, anesthesia. They're derived from the opium poppy. It's the dried milky juice from the poppy plant. Some examples of these chemically modified forms of opiates are codeine, heroin, oxycodone, and hydromorphone. It causes cardiac damage, basically affecting your cardiac enzymes like CK, CKMB, troponins, and overdose can lead to death caused by pulmonary failure. We screen these by immunoassays. So opioids are the types of drugs that include the illegal, drug heroin, fentanyl. Fentanyl has become very common and deadly in the last few years. Also, pain relievers available legally by prescription. So oxycodone is a type of an opiate. Hydrocodone, okay, so Vicodin, Oxycontin. So a lot of the prescriptions are now very, very strict and regulated for the overuse of oxycodone and Vicodin. Fentanyl is a powerful synthetic opioid. It's 80 times more potent than morphine. That since 2013 has driven steep rises in opioid overdoses. So codeine is actually a prescribed cough suppressant. Users can be way above the threshold. Morphine is a sedative, so it puts the person to sleep and can also cause respiratory distress when it's in high doses. Heroin is the most commonly used form of opiates. It has a rapid response. Usually it's given intravenously or administered intravenously. And the addiction of heroin is treated with methadone, and it will reverse the effects of it. PCP is next, and that's phencyclidine. And this is an illicit drug with stimulant, depressant, and hallucinogenic properties associated with agitation, hostility, and paranoia. An overdose of PCP can cause stupor or coma, and it can be ingested or inhaled or smoked. It's a lipophilic drug that rapidly distributes into the fat and the brain tissue. In chronic use, it can be detected for up to 30 days after abstinence. Immunoassays are done for screenings and GCMS for confirmatory methods. Barbiturates are a type of sedatives, hypnotics that can be abused. They're used in medical therapy. There are two classes. There's the slow intermediate acting or the long acting. They have a high potential for abuse, and overdose can lead to cardiac arrest. Some examples are secobarbital, pentobarbital, and phenobarbital. And then benzodiazepines. These are the most commonly used drugs to treat depression. They are a central nervous system depressant. They induce it's like a sedative, and they also have some hypnotic properties. The adverse effects on they have some adverse effects on the central nervous system, but it can also cause cardiopulmonary arrest, respiratory depression. Some examples are Valium, Ativan, lorazepam. These are most commonly found in abuse and overdose situations because of its availability. So basically, these are central nervous system depressants to treat anxiety, panic, disorders, and also sleep disorders. And alcohol, this is the alcohol that we drink. This is also measured in the laboratory, ethanol, alcohol. And people can drink to socialize, celebrate, sometimes to relax, but alcohol could have a strong effect on people as well. And throughout history, people have struggled to understand and manage alcohol's power, basically. So the toxic effects of alcohol are general and specific. It affects the effects cause disorientation, confusion, euphoria, but can also progress to unconsciousness, paralysis, and high level of exposure, maybe even death. Ethanol is the common leading cause of economic, social, and or alcohol is of medical problems throughout the world. It's related to the top 10 causes of hospital admissions, and about 80,000 Americans die each year as a result of abusive alcohol consumption. And so we can measure ethyl alcohol, ETOH, in milligrams per deciliter, but what you get as a report in the report is a percentage. So if it measures as 150 milligrams per deciliter, then it gets converted to 0.150%. The statutory legal limit in the US is 80 milligrams per deciliter, so that's 0.08%. There are about 40 to 50,000 annual automobile-related fatalities in the US that involve alcohol as a factor. Ethyl alcohol is metabolized to acetaldehyde and forms of acetic acid. It forms acetic acid in the liver. And the specimen of choice is a serum red top tube, usually the most common. Okay, so any questions with this one? No? Okay, hold on a second. Okay. So these are trace and toxic elements, chapter 27. And again, this is just a brief summary of the chapter. Excuse me. Okay. So basically, we are going to just review the trace elements that are often encountered in the clinical lab. About half of the elements that are listed in the periodic table have been found in the human body. So there are essential elements and non-essential. Essential elements are the ones that if a deficiency of the element impairs a biochemical or a functional process and replacement of the element corrects the impairment, then that is an essential element, basically. A non-essential basically is any element that is not considered essential. But with essential elements, it's like, so if there is an impairment in the biochemical or functional process, and if you replace that impairment and it corrects, you replace that element and it corrects the impairment, then that was an essential element. Essential trace elements are often associated with an enzyme, so they can be metalloenzymes or another protein, metalloproteins. Deficiencies are associated with impairment of one or more biochemical functions, and excess levels are associated with at least some degree of toxicity. The measurement can be made in any fluid or tissue. We primarily use blood. We may also use hair and nails to measure some toxic metal exposure. The collection is typically in a navy top tube. It's free of metal, so it's a container that is metal free. We must take extraordinary measures to prevent contamination of the specimen. We use special specimen collection and sampling devices, clean glassware, good water, purified water, and also reagents of high purity. The lab environment is usually controlled. We use a separate room with contamination control features. So I'm going to give you some examples of the trace elements or toxic elements. Chromium is the first one. Chromium comes from the Greek word chroma. It's also known or also means color. And so it's the 21st most abundant element that is used in manufacturing of in the manufacturing of stainless steel. It's used industrially. It's discharged into the environment as an industrial waste. Wood treatment, stainless steel welding, chrome planting, leather tanning industries. Chromium is also incorporated in the use of lead chromate or strontium chromate paints. Albumin and transferrin are actually involved in chromium absorption and transport. It's absorbed in the intestine. It binds to plasma transferrin, and the excess chromium gets excreted in the urine. So there's two different types. There's the chromium-6, which is better absorbed and more toxic, and chromium-3, which is an essential dietary element. It maintains normal metabolism of glucose, fat, and cholesterol. So the safe and adequate daily intake of chromium for adults is about 50 to 200 micrograms per deciliter. As an essential trace metal, chromium can enhance the action of insulin. It's the biologically active form known as the chromium is also known as the glucose tolerance factor. Low molecular weight intracellular octopeptide. It's a low molecular weight intracellular octopeptide, LMWCR. It's released from the cell to terminate release of insulin once the patient reaches the normal glycemic conditions. Some dietary sources of chromium include processed meats, whole grain products, green beans, broccoli, and some spices. Chromium-6 is a powerful oxidizing agent. At physiological pH, chromium-6 forms chromium-2 and passes through cell membranes due to its similarity to phosphate and sulfate oxime ions. Intracellularly, chromium-6 is reduced to reactive intermediates producing free radicals and oxidizing DNA, inducing cell death. Severe dermatitis and skin ulcers can result from contact with chromium-6 salts. About 20% of chromium workers develop contact dermatitis. Inhaled chromium-6 can cause respiratory tract irritation, resulting in an airway obstruction and possibly lung cancer. Deficiency of chromium occurs in patients that receive parenteral nutrition for prolonged periods of time. So parenteral nutrition is feeding of special nutritional products to a person intravenously, bypassing the usual eating and digestion process. Patients can develop insulin-resistant glucose intolerance, weight loss, neurological deficits. So the role that chromium plays in impaired glucose tolerance and diabetes is actually still under investigation, so it hasn't been confirmed. It can also play a role in cardiovascular disease due to the lipid response to chromium supplementation, which has proven to be a favorable response. In May 2011, the FDA issued an order for post-market surveillance studies to manufacturers of metal-on-metal hip replacement systems, MOM hip replacements, because there had been increasing concerns of overfailing implant devices reported in Europe. So it's under investigation. Testing for chromium includes, it can be determined by GFAAS, which is gas flame atomic absorption spec, ICP-MS, which is inductively coupled plasma mass spec, but basically GS, gas spec, and mass spec. We can use plasma, serum, urine, plasma, serum, and plasma, serum, and urine do not indicate the total body status of the patient, whereas urine levels may be used for metabolic studies. The next one is copper. This has copper has electrical and heat conducting properties. It's an essential trace element. Sorry, there's a typo there again. Trace element found in 4 oxidation states. So 0, 1, 2, and 3, with copper 2 being the most stable essential trace element. It's an important cofactor for metalloenzymes, and it's critical for the reduction of iron in heme synthesis. Some dietary sources are meat, shellfish, nuts, whole grain, cereals, and cocoa-containing products. It's absorbed and transported to the liver, bound to albumin, and then exported in the blood as ceruloplasmin. Ceruloplasmin is an acute phase reactant and increases during infections and after tissue injury. Copper is a catalytic component of numerous enzymes. It also aids in energy production, connective tissue formation, iron metabolism, central nervous system involvement. It's also involved in the degradation of serotonin in the brain. Menkes syndrome is a syndrome in which there is copper deficiency, and the symptoms appear as early as 3 months of age, and death can occur at the age of 5. It's a fatal progressive brain disease that's characterized by peculiar hair, like kinky or steely hair, and also retardation of growth. The clinical signs include progressive mental deterioration, coarse feces, a disturbance of muscle tone, seizures, and episodes of hypothermia. So a copper deficiency can increase the risk of heart disease and also lead to malabsorption disorders. Wilson's disease is actually a copper accumulation disease. So this can happen in patients within the ages of 6 to 40. This involves neurologic disorders, liver dysfunction, Kaiser-Fletcher rings in the eyes, which are the green-brown discoloration in the cornea of the eye that's caused by copper deposition. Early diagnosis of Wilson's disease is very important, and symptoms can be prevented, and the disease can be halted with zinc acetate or chelation therapy for copper. So with copper, same thing. We can use gas spec and all the specific types, AAS, ICP-MS. Serum copper and urine copper are used to monitor for nutritional adequacy and subacute management of copper toxicity. And then direct measurement of free copper and ceruloplasmin in serum is used to screen for Wilson's disease. So next is manganese. Manganese is the 12th most abundant element. It's used in the production of steel. It's associated mostly with the formation of connective and bony tissue, with growth and reproductive function, and with lipid and carbohydrate metabolism. Some dietary sources are whole grain foods, nuts, leafy vegetables, soy products, and tea. Manganese is absorbed in the small intestine and binds to transferrin. It gets excreted in the bile or the feces. It functions as a non-specific enzyme activator for these enzymes: superoxide dismutase, pyruvate carboxylase, arginase, and glycosyl transferase. A deficiency of manganese is very uncommon in humans eating natural diets. So symptoms include impaired growth and reproductive function, skeletal abnormalities, impaired glucose tolerance, and impaired cholesterol synthesis. Toxicity is associated with nausea, vomiting, headache, disorientation, memory loss, anxiety, and compulsive laughing or crying. Chronic manganese toxicity resembles Parkinson's disease with akinesia, rigidity, tremors, and mask-like faces. There's a condition called the manganese madness, the locura manganesia, and manganica. And this is seen in Chilean manganese miners with acute manganese aerosol intoxication. Molybdenum is an important carbon, nitrogen. It's important in carbon, nitrogen, and sulfur cycles. Some of the dietary sources are legumes like peas and lentils, grains, and nuts. It's absorbed in the intestine and bound to red cell proteins. It gets excreted in the urine. It acts as a cofactor for various enzymes like xanthine dehydrogenase, sulfide oxidase, and aldehyde oxidase. Deficiencies are usually not seen in humans with a normal diet. Toxicity, though, you can see some low toxicity in humans unless it is in conjunction with Wilson's disease. Selenium is the next one, and this is this element has chemical and physical properties that are very similar to sulfur. This is a constituent of the enzyme glutathione peroxidase, and it's closely associated with vitamin E and its functions. Some dietary sources of selenium are wheat, cereal, plants, and plants that take up the element from soil, but then they do not use it. Soil content is highly variable. It's absorbed in the intestine and then excreted in the urine. So in the 1930s, selenium was considered to be a toxic element. In the 40s, it was considered to be a carcinogen. In the 1950s, it was declared an essential element. And now, or in the 1960s and 70s and beyond, it was viewed as an anti-carcinogen. So a deficiency of selenium is associated with cardiomyopathy and skeletal muscle weakness and osteoarthritis. Cushing disease is an endemic cardiomyopathy that affects children and women in childbearing age due to selenium deficiency. They experience dizziness, malaise, loss of appetite, nausea, chills, abnormal electrolytes, cardiogenic shock, cardiac enlargement, and coronary heart failure. The Cushing-Beck disease is when there is low selenium concentrations, usually seen in northern China, North Korea, and eastern Siberia. It occurs during the adolescent years. Toxicity is associated with the garlic odor in the breath, hair loss, and damage in the nails. And that's due to high contents of soil selenium. So selenium sulfide, is considered to be a probable human carcinogen. The next one is zinc. Zinc is the second only to iron in importance as an essential trace element. It's used in the production of alloys, especially brass. Brass metal is used widely in decorative, mechanical, and architectural applications. It's an alloy metal that's made of copper and zinc. Zinc is also used in galvanizing steel, in die casting paints, in lotions, and for treatment of Wilson's disease. The dietary source is widely distributed in foods, mainly bound to proteins like red meats and fish. The bioavailability of zinc is dependent on the digestion of the proteins to release the zinc ions and to allow it to bind to peptides, amino acids, and phosphates within the intestinal tract. Deficiency is commonly seen throughout life, especially in individuals who do not ingest meat. And zinc functions in many different ways, but mainly it assists in numerous enzymatic reactions and nucleic acid syntheses. So it's involved in more than 300 enzymes. So in terms of zinc deficiencies, the diseases vary and are not specific. It can be depressed or stunted growth, increased incidence of infection, diarrhea, skin lesions, hormone activity will be reduced, and it can also have some neurological deficiencies. In terms of toxicity, zinc is relatively non-toxic, but high doses may lead to GI tract symptoms like abdominal pain, diarrhea, nausea, vomiting, and also a decrease in heme synthesis and hyperglycemia. Aluminum is the next one. It's the most abundant metal in the Earth's crust. It's applicable to industrial and household uses like beverage cans, pots, pans, airplanes, siding, roofing, right? Foil, aluminum foil. Adults ingest about 7 to 9 grams of aluminum per day in food, and it's absorbed in the intestines. Most aluminum is eliminated through urine and very little through the bile. Toxicity can occur in over-the-counter antacids that contain aluminum. So patients with renal failure won't excrete aluminum at the appropriate rate, so that can cause an issue. Aluminum toxicity is associated with encephalopathy, osteomalacia, or aplastic bone disease, proximal myopathy, increased risk of infection, microcytic anemias, increased left ventricular class, and decreased myocardial function. Arsenic is a toxin formerly used to kill humans. Non-toxin forms are found in many foods like shellfish, seafoods like cod and haddock, and it's the main current use of arsenic is a wood preservative right now. The arsenic toxicity is due to energy transfer. Arsenic binds to cofactor pyruvate dehydrogenase and inhibits the conversion of pyruvate to acetyl coenzyme A. It's inhibiting glycolysis. Arsenic can be detectable in hair, skin, and fingernails, but it's dependent on the length of exposure. Lead is used in the production of storage batteries, ammunition, solder, and foils. It's used as an additive to gasoline. Lead-based household paints were banned in the US in the 1970s. Toxic concentrations of lead are found in areas next to homes, painted with lead-based paints, and around highways where it has accumulated from past use of loaded gasoline. There's no known role of lead in the human physiology. Exposure is respiratory or gastrointestinal. Enhanced GI absorption occurs in children younger than 6 years of age. 99% of absorbed lead is taken up by red cells, where it can interfere with heme synthesis. It gets distributed to soft tissues, the liver, kidney, and the brain. So lead is excreted primarily through urine, feces, and some amounts get excreted through hair, sweat, and nails. The clinical presentation of toxicity is variable. So children over 60 micrograms or higher start to see the symptoms. There's an IQ decline that's seen in children with blood levels over 10 or higher. Clumsiness, gait abnormalities, headaches, behavioral changes, seizures, severe cognitive and behavioral problems, abdominal pain, constipation, colic, and acute nephropathy and anemia could also happen. So the CDC estimates an incidence of more than 450,000 for children with blood levels that are higher than 10 micrograms. So lead exposure rises basically in two settings: childhood exposure through paint chips that they ingest, and through adult occupational exposure. So smelting, mining, ammunition, soldering, plumbing, ceramic glazing, and construction industries. So we can test lead in whole blood. We can check for blood lead levels. And circulating lead is mostly associated with red cells, so we don't use serum or plasma. And treatment is it has to do with removal of further lead exposure, and parental education are the essential parts to management for patients with blood lead levels, elevated blood lead levels. And that's it. So again, this is just a summary of your chapter.